Fantastic talks. Thank you so much to both of you. As you will expect, come and sit. There's loads and loads of questions, so I'm going to try and organize them. Only allowed three. Is that what I'm told? Only allowed 3 questions. 3 questions. Okay, well, we're going to start with the bladder. I think the whole conversation around urinary incontinence is a really difficult one for lots of people to just even begin to talk about. So we've been talking about the various mechanisms that can lead to that, but I wonder if we could just explore the kind of the social aspects of this and the way in which you even begin to engage in those conversations. And the question that really triggers this is, when should I do something about my incontinence? And I thought that was a really intriguing question. What are your thoughts about how much you tolerate this and when do you do something about it?
I tolerated it for a long time and was like, all right, this is just how it's going to be. But then when I started feeling better in other ways and getting out more, I realized I couldn't be away from the house for more than an hour if I didn't know where a bathroom was, right, or it was just going to be puddle city. So I'd have to go home and change. And so I didn't really want to go anywhere. It was really when I decided that I wanted to really get back out there, start living my life, that I probably need to take care of this. So I went to the EDS Society, they gave me the answer, and then I went and got what I needed.
Yeah. So it's a lot about how much it's actually affecting your day-to-day life.
Yes.
Just, I mean, in terms of your inquiry when you're seeing people in the clinic, how do you explore that?
So
I think you just slightly twisted
for me, it's always part of my history taking. But if you're going to be going to your primary care or you're going to your gynecologist, they're going to ask you, do you have any, do you think you have a bladder infection? Are you having any symptoms? Well, now it's on you. Take it to the next step and say, you know what? I may not have pain with urination, but I have noticed that I've started to leak a little bit more. I'm leaking when I cough, when I sneeze, or gosh, I just can't make it through the night because I'm getting up 5 times a night to try to urinate. Start the conversation, be your advocate, because quality of life is so important. And again, like I said, pelvic health is so under-recognized, underrepresented, and not discussed enough. So.
And one of the other themes that's coming through on some of the questions is the change in symptoms and concerns as one goes through the menopause. Do you notice more issues around urinary incontinence around the time of menopause? Is that a picture?
I haven't quite hit menopause yet, but I do sweat all night, every night. But that's actually because of my POTS, so I'm told, not because of menopause. But yeah, I'm kind of terrified to see what gets worse as that continues. So I am also really interested to talk about other ways that we can even further help manage our problems when we do hit menopause.
Mm-hmm.
So yes, the answer is with perimenopause and menopause, you're going to notice probably an increase in some bladder and bowel issues, but mostly bladder. Now, there are estrogen receptors in the bladder mucosa, and when your estrogen drops, obviously it's going to affect your bladder. So you're going to have some thinning of the bladder, and that changes in the bladder mucosa overall. And what that does is it increases your risk of urinary tract infections. Now, if you have no contraindication to estrogen use, one of the easiest things to start with is vaginal estrogen. And though it will help not just the vulvovaginal health in those tissues, but it'll actually also play a role in improving the bladder health and decreasing your risk of infections. So, yes.
Yep, definitely. Just another one of the issues that everybody has to think about as part of the menopause. Thank you. Some questions around some of the issues with having investigations of the bladder, concerns about use of local anesthetics, safety of colonoscopies, I'm in the wrong session, of cystoscopies in people with EDS, your experience of the things to look out for.
Cystoscopies actually can be done awake.
Right.
So,
but with local anesthetics?
With a little bit on the cystoscope during insertion, but overall I think the pain is probably not intolerable. So, but yesterday when they kind of mentioned a local, and I can't remember the name offhand, I was going to write it down, but there's certain local anesthetics that work better. It's a bit of a trial and error, but it is always good to point out that, hey, you might need to use a little bit more or repeat dosing when you're doing this. or perhaps use a smaller scope. So.
And would there be any concerns with tissue fragility with a procedure like that?
So with cysto, I'm going to say no. But if it's cystoscopic biopsies or you're going to get Botox treatment, intravesical Botox treatment inside the bladder, then yeah, because you can have bleeding points from every Botox injection, and there's quite a few. I think there's about 40 per treatment. So yeah.
Yeah. Questions around pelvic floor pain and also spasms. So vaginismus and dyspareunia. I think it's probably an extremely common concern. I know there have been a couple of papers published recently that demonstrate how much of a problem it is, but also how difficult treatment can be. I wondered if you could share your experiences of the treatments that have been successful.
Okay, for me to start? Or?
Yeah, I haven't had any yet.
Sure.
Treatments that have been
Do we need
successful.
to make an adjustment?
Oh.
Thank you.
Okay. Is it on? Can you hear me?
I think that worked. There you go.
Okay. Sorry about that. So the question is about painful intercourse and dyspareunia. So again, I'm going to sound like a broken record here, but it's going to be one, you got to talk about the topic. You got to bring it up to your providers. Don't be embarrassed. This sexual quality of life is so important. We know that if sexual quality of life is good, it's going to improve your immune system and overall life. But as far as you got to see what's causing the discomfort. Is it just an issue with estrogen? Is it because your tissues are thin and they've kind of, gotten fragile? Is it introital? Is it discomfort at the entrance? Is it with deep penetration? Is it a pelvic floor issue? So is it just, will over-the-counter lubricant help just decrease the friction injury? Or is it you need, over-the-counter non-hormonal vaginal moisturizers to plump and hydrate the tissues to get them optimized? So there's different things. Or is it because you haven't had intercourse for a while or any penetration and you've had some atrophy set in your vaginal diameter, your introitus is starting to kind of get stenotic? And that's a whole different story. You got to prime the tissues, optimize the tissues, and then you may have to introduce graduated dilator therapy, which means you start with these silicone dilators. They're usually about first size, about pinky size, and you lubricate really well and you start inserting them in a quiet place where nobody's going to barge in, open the door and say, "What you doing?" But you want to relax when you insert. Make those pelvic muscles relax so you're not tensing. And the more you tense that vaginismus, the longer this goes on, those muscle fibers get shorter and shorter, and it becomes this vicious cycle that just perpetuates itself. So pelvic floor therapy, you can get Botox injections, you can get pudendal nerve injections, you can graduated dilator therapy, optimize the tissues. And sorry, probably a long answer.
No, that's a great answer.
But there are options, which is awesome.
And there are options.
Yep.
I wanted to explore with you, Lauren, your experience of using cannabinoid-based or medical marijuana-based analgesics in general, because you raised it in relation to the concern with medicines that are used for bladder and pelvic problems.
Right. I was really surprised when I was reading through the pamphlet and saw that there was an interaction with THC, because I had never found any other drug to have an interaction. One of the reasons I really like medical cannabis is because it doesn't interact with anything else. So I know it's pretty safe for me to take. When I realized it was going to cause all these other problems, it was kind of terrifying thinking what the drug does to my body that the marijuana also does that would create scromiting, which, I definitely didn't want any part of. But, when I say medical cannabis to doctors, a lot of them, even though it's legal in Massachusetts, they give me, the look. And I'm like, well, do you have anything else? They're like, no. I'm like, okay, thanks. I don't know what else to do. I've had to advocate for myself. I've had to find these treatments for myself. So do whatever basically works for you. Everybody's going to have their opinion on something. I think it might have something to do with cannabinoids, as I was looking into. And I guess there's also a stomach condition that if you have too many cannabinoids, you can just start vomiting. So when I was having stomach problems, they're like, it's the marijuana. I'm like, no, it's not. I said I stopped for 3 months, got it cleared out of my system, Worst 3 months of my life, just to let you know. So, you got to do what you got to do.
Shilpa, there's a very specific medical question here about the use of medical marijuana vaginal suppositories as an analgesic. Do you have any experience
I
with
have
that?
no experience with it.
So I live in Florida, and Florida's not a very happy state, so I don't have experience with that. But I'm open to it if anybody else out there has had experience and wants to share. Okay, crickets.
No.
All right.
So
Need for more research.
I'm so sorry that you live in Florida. Somebody has to. I don't know why I said that, but anyway. I've been thrown right off course. Okay, here we go. Hormones. Let's talk hormones. Right, so there are lots of questions around, first of all, around the use of oral contraceptives and the positive and the negative impact that they can have on other aspects of your well-being in EDS and HSD. So who wants to start?
All right. I had kind of briefly mentioned, it's a common question I get. So should I stop my birth control pill in my EDS clinic, right? So it's like, and I'm like, no, please don't stop, because why were you started on it, right? So a lot of times it is for menstrual cycle control, whether it's painful cycles or heavy flow and you got anemia. So no, but like I said, there are other options to explore, and one of my favorites for women with EDS would be a progesterone IUD, just because you don't get the systemic effects from taking a birth control pill that has estrogen and progesterone. So, but I would definitely say do not have a Nexplanon placed, because that's a procedure for placement. It's a procedure for removal that you don't need, and it's systemic progesterone. So,
Right.
yeah.
I mean, one of the reasons I was advised not to have the depot is that if it's going to go wrong, you don't want it stuck there for 3 months, right? Yeah. Some of the questions have been around the tolerability and the safety of an IUD. What's your experience of treating with IUDs?
IUDs now are very safe, right? You have, the risks would be infection, the risks would be very low, right? Because they're placed sterilely. The bleeding profile, one in 5 women, so 20% will have amenorrhea or no cycles after placement of a Mirena, which is good. Migration can be a risk. We had one patient, she didn't have fibroids, uterus was normal anatomy. We must have placed 4 IUDs in her. 2 in the operating room, 2 in the clinic, and finally in the operating room, and her uterus just did not want to accept. It kept expelling the IUDs, and we couldn't figure out what it was. We even tried a smaller size. So I think it's not like 25 years ago when, IUDs were just not in vogue. The safety risk, it was the copper 7, I believe, that was causing a lot of problems with, migration through the uterine wall and infection and issues like that. So migration can still be an issue, but I think overall, hands down, if somebody says, what do you think about IUDs? And we're like, yeah, definitely worth a try.
Yeah. So I should say that's intrauterine devices if people aren't sure.
Oh, sorry.
No, that's my fault. That's it. And I also write in thinking that they come in different doses, so you can try something that's a little bit lower in dose.
Yes, they sure
you
do.
can
And the
build them up.
lower dose is a bit smaller too, as in size, but not
Right.
significant enough, I think, to cause issues with placement or retention. So.
Okay.
I just wanted to ask you, do they put you under when they put those in usually? Because I've had 2 friends who've had it and they're like, never again, worse than childbirth, don't ever do it. So
I don't like, and I'll have a very, in-depth conversation, like, have you had a procedure before? Do you like to pass out? I mean, did you have breakfast first when you come in? But the question then is, if somebody comes in and says, I will not have one placed, but I think that's the best option, then it's a referral over to my old department in medical surgical gynecology, where they will then take you to the operating room, right?
Right.
So yes, it can be painful, but overall, if it's done in a proper manner, cervical dilation, things like that, I think prepping and having that discussion with the patient so they know when to anticipate what's coming, pre-medicating with some ibuprofen if you tolerate it. All those things help. We have ice packs, heating pads ready. So, the minute we're done with the procedure, like, what would you like? A heating pad, ice pack? Would you like to lay there for a while? I think it's just the approach also. So.
Right.
And your pain tolerance, right? So,
yeah. Thank you for that. So moving sort of through the hormone conversation to hormone replacement therapy.
One more thing on IUDs, sorry.
Oh, go for it.
Sorry. If you're concerned about pain during insertion, sounds gross, but pain during your menstrual cycle is less discomfort. A little higher risk of expulsion, but less discomfort. Sorry.
No, not at all. And I think it's worth just reminding ourselves that there's significantly growing literature on pain from normal, well, you can't use the word normal, but from menstrual bleeding, both extremely heavy and extremely painful. And so, a lot of patients are actively seeking hormone treatments that might influence that. So if we could sort of move on to hormone replacement therapies in that context, what's your guidance there in terms of the way to manage that?
Okay, all right. Well, again, it depends. What is the cause? What is causing the bleeding? What is causing the pain? So, real quick review, right? Endometriosis is endometrial lining implants that are not where they're supposed to be. So, they're outside the uterus. They can be in the fallopian tube. They can be peritoneal wall. We've even had somebody who had thyroid endometriosis. So, I won't go into the pathophysiology of how that happens. There's a lot of thoughts on that, but so is it adenomyosis? And what is adenomyosis? Well, it's that lining of the uterus, again, not where it's supposed to be. It's not in the inside lining of the uterus. It's caught. It's trapped in the wall of the uterus, right? So adenomyosis leads to really heavy bleeding, painful cycles, just like endometriosis can, but it's a slightly different kind of mechanism there. So when you bleed, when you have a menstrual cycle, those implants are bleeding. So what's the key there? Shut down the cycle. Right? So that your implants aren't bleeding. Because if you have peritoneal implants that are bleeding every time you cycle, your body does not like that. And it's going to kind of start this cascade of trying to fight that, and inflammation and pain, peritoneal irritation and peritoneal pain. Now, if you're having pain symptoms from ovarian cysts, that's a different intervention. So, but overall, I think birth control pills are really good in a continuous manner for treatment of endometriosis, adenomyosis, and we do know that unlike IUDs, right, which work locally inside the uterus, like for instance, birth control pills will actually, they take over control. So your ovaries are basically shut down and they are kind of managing everything. So if you're going to take birth control in a continuous manner, which means that you don't allow for a withdrawal bleed during the sugar pill week, that definitely helps. Now, kind of not jumping to the hormonal intervention, believe it or not, scheduled dosing before your cycle of ibuprofen type products, because that's where the prostaglandin connection comes in. And prostaglandin is notorious for causing painful cycles. So if you can shut that down, then hopefully it'll help. So and there's other medications like Orlissa and things like that out there too. So
thank you. We're making the medic work really hard here. I'm trying to, I don't want to ask you questions, Lauren, about the menopause, because I think that would be terribly rude of me. So, I mean, a lot of individuals experience a number of different symptoms at menopause. And certainly from a rheumatologist perspective, we see flares in their musculoskeletal concerns. And I just wonder what your sort of assessment and guidance is around the use of estrogen therapies at that point in their life.
So, where I work, we follow the guidelines of the Menopause Society, and there are very strict indications for systemic HRT use. Treating joint pain is not one of them.
Yep.
So, can hormone therapy help with joints? Yes. But if somebody came in, they weren't having vasomotor symptoms, hot flashes, night sweats, things like that, they said, put me on hormones, I need it for my joints, probably not going to happen, at least in my clinic. So, again, we should be looking more at quality of life, but again, hormones are not without risks, right? And we always have to weigh risk versus benefit. And we know that there's papers out now regarding the timing hypothesis or window period, which means that the first 5 years after menopause defined as 12 months of no cycle, is the prime time where you're going to get, it's more than even BOGO. It is You're going to optimize the benefits from the hormones for cognition, your brain health, your heart health, and bone health. So,
yeah. And the bone health question comes in at that point, so it might be another way to think about the need for those treatments, even if your main concern isn't indicated, if you like, in terms of the choice of treatment.
So one of the indications for systemic hormone therapy actually is not treatment of osteoporosis, but prevention of osteoporosis. So there's a difference there. So,
right. Thank you for that. We have a couple more minutes. There have been a couple of questions about pregnancy, and I'd just like to say that Sally Pizarro and colleagues from the Pregnancy Working Group in the International Consortium have just published the most amazing consensus paper for midwifery and obstetrics, but has absolutely been written in a way that I find that my patients have found really, really helpful. So I'm not sure who I'm going to ask in the room, maybe Sarah just down at the front, to see if we can actually get reference for that onto Hoover in some way for everybody, and it'll answer, I think, a lot of the pregnancy questions. But I'm going to, I don't know, maybe I'm completely out of turn here, but I'm going to ask for anybody's experience, your own and any of, the people that you work really closely through all your social media work, of, concerns around pregnancy.
Yeah, I mean, I see a lot of people mentioning, because of course no one gets the diagnosis before they get pregnant, right? So they're having a baby and all of a sudden, like their pelvis will separate and they'll be like, oh, that's so weird. Why'd they do that? I think for me, because of the health problems that I was experiencing and because my health kind of took a dive at 35, that time for me to have children kind of passed because I didn't feel well enough that I thought that I could carry a child. And considering I couldn't fix some of the problems I was already having, I didn't want to, add insult to injury. So for me, I've decided that, not having kids is probably the way to go, but to definitely help others decide if that's the right choice for them.
And Shilpa, one of the big concerns that a lot of people ask is whether pregnancy actually increases the risk of prolapse at a later stage. Your experience of that?
So we often ask during our evaluation, what was the weight of your largest child at birth? Vaginal delivery, obviously, because that's going to play a role. Did you have a forceps delivery? Things like that. Did you have an episiotomy? Interesting, if you have hypermobility EDS, HSD, they say that you are less likely to have an episiotomy because your tissues are going to actually stretch. But if you have vascular EDS, then, there's a lot more risks. There's risks of placental abruption even before, there's risks of postpartum hemorrhage. So, kind of the vascular EDS subtype, you definitely have to be a bit more aware and cognizant of. Your OB should be very much cognizant. Kind of off topic, but my mom, who I think is hypermobile, but she doesn't believe me, she's had like 5 miscarriages and all from cervical incompetence. I'm the only baby that survived because she had a cerclage done. And that is basically stitching up the cervix so it doesn't start to thin out and want to kind of open up. And even with that and bed rest, I was born at 28 weeks. So I've had 2 pregnancies. I am hypermobile, but knock wood, I did not have any pregnancy issues, but I did have postpartum issues with my SI joint and my pubic symphysis wanting to kind of separate, where walking became more of a waddle. So, but God bless pelvic floor physical therapists, because they got me through it. So,
which is a good segue into the next session on hips and pelvic floor. And I should just also add that there has been a great guidance paper for vascular EDS that was produced also around about the same time. So Sarah will get that one on there too, from the Sheffield team in the United Kingdom. Thank you so much, Shilpa. Thank you so much, Lauren. Round of applause for our speakers, please. Thank you.